Welcome to Field Notes, the podcast looking at policy and innovation in public safety. The relationship between healthcare access and public safety is an area of growing interest for researchers and policymakers. In particular, the question of what happens to people's healthcare when they enter and leave the justice system. In this episode, Jennifer Doleac talks to David Ryan from the Health and Reentry Project, or HARP, about how healthcare can improve public safety. They cover the current challenges, the policy landscape around Medicaid and incarceration, and what HARP is doing about it. This is Field Notes.
So, David, let's jump right in. Can you give me a real-life example where you've seen Medicaid intervention make a difference to an individual who's left prison?
Certainly. Thank you for the question. So prior to joining HARP, I spent 10 years working in a local jail where we actually had a medication-assisted treatment program offering all three forms of MAT in addition to counseling. And what we were doing before the Medicaid waivers were put in place is that we were making sure that we were enrolling folks in Medicaid prior to their departure so that we could actually make appointments within the community so that they could have continuity of care as they were leaving, because we would begin administration of MAT behind the wall, but we would want to make sure that they could also receive that within the community. So we would make those appointments as well as provide case management that would follow folks into the community and help assist them with the follow-up care that they would need and connecting to additional services within the community. And one positive piece that we saw out of that, just looking at 1 year, we saw that the recidivism rate for those individuals was hovering around 10%, which if you looked at the overall facility, I think it was around 25%. So
wow.
where you could actually have like evidence-based programming and treatment and then a connection to care within the community, but also bolstered by Medicaid coverage. We were starting to see some positive signs.
All of that effort sounds really unusual. It's obviously a lot of work for a jail to be doing this on top of, just keeping people safe while they're incarcerated. That's the day job. What prompted you all to want to do this?
I think when we first started, folks would grab us, and I think we came in and it was like 2011, 2012. And a lot of folks are talking about inmate healthcare costs. Mm-hmm. We're like, yep, no, that's a valid point. We should take a look at the cost. But we also wanted to look at the data to understand like how sick is this population.
Yeah.
And I will say, like going back 10 years, maybe we didn't have all the data we wanted at that point. But when we started to gather it, and I'm going to read just a few stats that I had jotted down. And again, this was back when I was at the jail, and it's been a minute since I've been there. But I think that these numbers still track is about 48% were diagnosed with an SUD, around 56% with a diagnosed mental illness. And the one piece that I don't think we talk enough about is chronic health. So that was hovering around like 60 to 70% folks with chronic health, and that could be diabetes or that could be hypertension and the rest of it. So you have like a very sick population. And also you have folks that are entering jails across the country that are actively detoxing. So like that's also very dangerous, especially when we talk about alcohol, to make sure that you have medically managed detox and the rest of it. So those numbers were alarming to us. And so like we have to make sure that we're establishing the necessary pathways for continuity of care so that folks maybe can remain in community and not come back and actually, receive the care within the community. Because I will say also, it is a wear and tear on correctional staff and the healthcare staff at the jail to have to care for folks that are so acutely sick. And the rest of it. And there's a little bit of mission creep, I find sometimes, where, we have, corrections officers whose job is security, where they're playing a little bit more of like a social worker type of role. But, one thing that we did, because it was necessary, is we trained all of our officers in CIT so that they could recognize signs and symptoms. Because historically, what would happen is that they would have someone who they thought was behaving badly, but they actually just had an unrecognized or undiagnosed behavioral health issue that was like impacting their behavior.
Yeah.
So
training those officers to be able to recognize that and intervene
exactly
more effectively.
Yep.
Amazing. So briefly give us an overview of what HARP is trying to do.
Certainly. So first and foremost, we want to make sure that we're improving health outcomes and we're improving the public safety of our communities. what we look to do is like through education and analysis is to strengthen policies, but also access to care for individuals. And then I would say the third main component is we're supporting implementation in the field of these new policies. So that would be through the 1115s and through the youth continued care requirements. Right now, through a learning collaborative, we're in 7 different states. And we're also in 12 different counties in California. So we're actually watching the implementation happen in real time. And it's a lift of work for sure. And it can be messy. But I think the one encouraging thing is that it's happening, right?
Yeah.
Like we're seeing it across California. We're seeing it in Washington. We're seeing it in New Mexico happen. I think Kentucky is going live at the beginning of October. So all great signs, but the process for implementation has been a lift for these jurisdictions. So we're trying to support them as best we can to make sure that, when, questions come up, which are starting to turn to like evergreen questions, that we're able to like support them and get those questions answered.
You joined HARP just recently, 2024. What conversations persuaded you that this was the right next step for you?
I started my career working in the U.S. Senate and working on sort of justice and health issues. And then after that, I went to law school, practiced for a bit, and then had the opportunity, obviously, to work for Sheriff Contusion. And the work on the health and justice pieces continued. I didn't think starting my work in the jail that we would be such a focus on health, because I wasn't aware of like the number of folks that were in jail that had acute care needs and how we really needed to kind of step in further and assist. But so like 2 main parts of my portfolio. One was on crisis, diversion, and deflection, and the other one was on reentry and how to utilize Medicaid as a reentry tool. And so, after 10 years, I had the opportunity, obviously, to work with Vicky and team over at HARP as a strategic advisor. And then the opportunity came because we had finished some of our work with the crisis diversion facility. Massachusetts just got their 1115 waiver approval. And I thought that this would be a great opportunity to kind of step in a little bit deeper to be able to help more states, because played a big role in trying to help Massachusetts through the process from like the jail perspective and the corrections perspective as they were, sort of moving through their proposal process. But I really wanted to sort of expand that and be able to, assist more states with that and provide additional perspectives. Because the one thing I will say in this process, which is driven largely by the state office, the Medicaid offices in each state, is that the corrections perspective is really important to this conversation, because there are things, and this is no fault of anyone, that sometimes they're not seeing in the corrections space, things that are security, physical plant restrictions. Like one component of the 1115s is 30 days of meds in hand upon release. And if you say that to a health services administrator within a jail, it's a little jarring, because like that's a lot, right? So like, where are you going to put those meds? How are they going to be secured? So I think providing that perspective, I think will help the implementation of these policies be successful. So that was sort of one of the main motivators for me joining HARP, and also just a great team over there with Vicky and team. So
Yeah. So let's talk a little bit more about the context here that all the corrections officers, the corrections staff are working in, and the problem we're trying to solve. So can you talk me through the incarceration process from that medical perspective? What are the quality issues that jails and prisons are facing when it comes to medical care? And how could Medicaid access potentially affect that?
That's a really great question, because the one thing that we do say is if you've seen one jail, you've seen one jail, right? So it's all sort of handled differently. And so like moving from that, each jurisdiction sort of has a handle on how they deliver correctional health care. With this, because of the Medicaid program, because of the quality and accountability that is built into the program, in addition to the opportunities for scalability and accountability and evaluation and the rest of it, we do have an opportunity to create some level of uniformity across the delivery of healthcare within the jails, because just historically, obviously these jurisdictions have had to shoulder the burden financially and also having to deliver these, and that this is an opportunity to right size some of the resources and provide support for correctional administrators who are trying to set up folks successfully upon reentry.
Yeah. I think something I've learned that's been fascinating to me is just, I think a lot of people take for granted when they go to their doctor, they go to a hospital, that there is a basic requirement of quality of care. And that's really all coming from requirements from Medicaid and Medicare in order to get those reimbursements. And since jails and prisons are not getting reimbursed through Medicaid or Medicare, there basically are very few rules. Is that fair? Is that fair to say? Or there are different rules?
You're right. And there's levels of oversight, right, that occur from like departments of public health and mental health. And there's levels of oversight, I think, with departments of corrections and the rest of it.
Yeah.
I think the one thing that I have noticed in working at HARP is that in different jurisdictions, it's just handled differently. And so being able to, I think, sort of improve the continuity of care for those individuals by establishing a process for folks to become enrolled, receive some services pre-release, and then making those connections with the community could really have a great impact.
Why is getting insurance back when people come out of prison so difficult? Why don't they just sign back up for Medicaid? Why is it so hard?
No, it's a really great question because I remember back when I was working in the jail, the way that we started out before the 1115 waivers were in place is that there was a practice, which we changed, where folks would just get handed a paper application to sign up. And the Medicaid application is like 30 pages long. And, shocking, like that didn't really work well to actually get folks signed up. So what we actually ended up doing is we had full-time staff that would get certified as application counselors to help folks to be able to sign up for Medicaid so that they had that coverage, and then they could connect to care on the outside, which was hopefully facilitated by reentry specialists or caseworkers. So they made sure that they had the opportunity to connect to care. And now we have the opportunity where, Medicaid's getting turned on behind the wall. So you have that continuity that's going to follow you within the community so that you can be able to hopefully seamlessly, without gaps in coverage, be able to re-enter, because that process is all starting at the beginning. It's almost pushing it all the way towards intake as opposed to something that you're getting handed as you walk out the door. So it's sort of like flipping the process so that we can make sure that there aren't any sort of gaps when folks leave.
Yeah, because when people leave, they've got a lot of other things to figure out, and health insurance is probably not the very top of their list.
Exactly.
But it helps the rest of us if they have healthcare. So as I mentioned earlier, from a research perspective, there's just so much evidence at this point that access to healthcare it makes a big difference to public safety. So we have evidence that state Medicaid expansions to cover low-income adults without dependent children have reduced crime rates in those states. We have evidence from South Carolina that when young people age out of Medicaid at age 19, they're suddenly much more likely to become incarcerated. And what's especially fascinating to me is that effect is really concentrated among people who were relying on Medicaid for mental health services, and especially medication related to mental health. We have evidence from Wisconsin now that efforts to increase Medicaid enrollment for those leaving prison dramatically reduced the likelihood that they were reincarcerated in the state. So for those of us who are coming from that research perspective and the public safety perspective, access to healthcare has become a really important and exciting crime reduction strategy, which I think most people don't think of it as. And you're coming at this from this law enforcement angle. So say a little bit more, I know we talked about this up top, but say a little bit more about what you saw that made you want to work on this.
I think one thing that has sort of struck me throughout this process is like the public safety plus up here and the opportunity to improve the safety of our communities if folks are actually connected to care. And one thing that we've really been encouraged by is that this issue at the very beginning, going back to like 2015 timeframe, has garnered the support of national law enforcement organizations, which has been really encouraging, and also been able to maintain that bipartisan support moving forward throughout this. So that's something that really drove me into this work, is the public safety piece of it, but also the ability to improve health outcomes, obviously for individuals who are returning. And also there is a cost side to this as well, because this is anecdotal, but it may cost like $100,000 to go to jail a year, which there's potential to create cost savings and efficiencies when we're talking about using taxpayer dollars. So that's also something I always sort of say, like, no matter where you're coming to this issue, from whatever sort of perspective, if it's the public safety or improving health outcomes or the cost savings or creating efficiency, like there's something in it for you. And that's why I feel like we have such a broad stakeholder support that has maintained over time, and it's been bipartisan, which is encouraging.
Yeah. Okay, so this leads us into these 1115 waivers. Talk a bit about the waivers, why we're talking about them now, and the opportunity they've opened up.
I don't think anyone envisioned that our jails and prisons would look the way that they do, and that we have the high number of individuals with acute care needs behind the wall. And so now there's been a recognition, and there's sort of change underfoot with what we call the 1115 waivers, which the Centers for Medicare and Medicaid Services, which is the federal agency which oversees Medicaid, they have broad, not total, authority to change some areas of the Medicaid law. And so through waivers. And this is one way that they're doing to address some of the needs and right size some of the resources that are needed but there are parameters. You go up to 90 days of services behind the wall. And there's sort of three key components. There's the case management piece of it. There's MAT, medication-assisted treatment, all three forms. And then also, which I mentioned earlier, was the 30 days of meds in hand upon release, to make sure that you have sort of, again, that continuity with folks having medication upon release, which is really important, because sometimes when you're leaving, you can't stop by the pharmacy in those pieces. The other component to this, which is important, is the youth continuity care requirements, which is those went live January 1 of 2025. And for the 19 states that have approved waivers in this space, they can actually, and this is a Medicaid terminology, so forgive me, but they can subsume those requirements into their waivers. And what that does is that requires diagnostic screening, targeted case management for folks that are under 21 or former foster care youth under the age of 26, which is such an important group of individuals that could really benefit from like targeted intervention. So that's a really encouraging component to this.
And I guess the idea here, because they are waivers from the standard rules, is that these are experiments. And the idea is that hopefully we'll all learn what works as all these different states are trying new things. Is that the idea?
Yeah. So this is a demonstration, right? And it's something, what's part of this, which is actually exciting, is evaluation and monitoring is part of the requirements. So over time, like we'll be able to actually see. The other piece of this too, and one thing that I think some jurisdictions are already picking up, is trying to actually track some metrics earlier on, because we want to see somewhat the short-term impacts are, but then through the waiver, we'll see sort of longer-term impacts of the implementation of these policies have had for jurisdictions.
Great research opportunity for people who like that sort of thing, which I do. So who can apply for these waivers? How does this work in practice if a state hasn't signed up yet? How could they do that? This
is obviously voluntary, right? If states want to do this. And like I said, we have the 19 approved and the 8 that are pending, but any state can apply for these pieces. And obviously they just have to keep it within those parameters of the 90 days in those 3, but they can expand upon that. Like an option, for example, that we did was durable medical equipment. One thing that like I didn't realize until we actually looked at the data was the number of folks that actually needed things like canes and walkers when they left, especially when you're looking at a population that is graying within corrections. And the rest of it, that they actually needed the durable medical equipment. So you can sort of tack that on to your waiver and have it be a component part, which, I would certainly encourage jurisdictions to do that, because that's a needed service in the rest. But you just have to hit the core components, and then you can sort of tack on additional where folks or jurisdictions feel that it's necessary.
So how much do you think people are aware that all of this is available?
It's slowly, I think, starting to come to the forefront a little bit. And, one thing that HARP has been doing is a lot of education. We try as much as possible to be sort of on the road educating, stakeholders, policymakers, that this opportunity is available. And also, the one thing that a lot of policymakers will be asking from us is, is there data? And so what we're trying to do is point to some of the data that is available. As you highlighted, one study that we cite regularly, I'm going to read this here a little bit, is from 2022. And it found that having Medicaid coverage reduced rates of incarceration by an estimated 40%. among young men with mental health conditions in South Carolina. So when we come into these conversations, we do come at it from an approach of like, why do I care about this? Like, why is this important? Why should I be? Because it is a lift of work for states to take on, but one that we feel as though obviously has value, and that could obviously increase the safety of our communities and improve the health outcomes for individuals. So, who wouldn't support that?
Yeah. Yeah. And I think that's, I think a lot of people who might have been thinking about the quality of care in jails and prisons often worry that people aren't getting good enough care. And it's entirely from more of a social justice perspective or concern for people while they're incarcerated. And that's wonderful, but not everyone is equally concerned about that. So I think really driving home, like this is a public safety issue.
Absolutely.
This healthcare helps people get on a better path when they get out of jail and prison. That makes us all safer.
Absolutely.
So thinking about this as a crime reduction strategy, I think is a new angle. And so I'm really glad HARP is working on this. So what else? What else is HARP trying to accomplish here? What else do you do in your day-to-day job?
Between the waivers and the youth contact care requirements, there's really not a lot going on. Kidding. I think the support on the ground is really like a key focus in making sure that jurisdictions have all that they need, because some of the evergreen issues that are popping up that we're seeing are things like data sharing, right? And so you're talking about establishing MOUs and data sharing agreements, and sometimes that may be new, but also you have two systems that are coming together, justice and health, who are historically siloed. So a lot of like stakeholder building is, are also going to be really important. Looking at things like expanding technology behind the wall. You have, electronic medical records that need to be captured and shared. You have eligibility and enrollment systems that need to be put in place. There's billing, and corrections has never done billing before. So really kind of rolling up our sleeves and getting to work on sort of those pieces and setting up, that transition where we can share information so we can actually coordinate the care at that level. And these, learning collaborators, the work that we've been doing in California have really sort of highlighted, where the need is. But, the other thing that I mentioned earlier, it's just really encouraging to see this implementation that's actually going live. And it's been really positive, and it's been challenging for jurisdictions, but it's really been exciting to watch them put one foot in front of the other and have their heads down and actually doing it. So, which is great.
Let's dig in a little bit more on just the logistical challenge here, because I think people hear this and they're like, great. So now jails and prisons can build a Medicaid. Easy, right? And it's been fascinating to think about. You've got these two big bureaucratic systems that, have their own problems. I work mostly in the crime and criminal justice space, and data systems in that space are notoriously, not what we would want them to be, let's just say. And so that's a lot of work that people have been trying to do for a long time on its own. And now we need to have these two big data systems, these two big bureaucracies speak to each other, work together. It sounds like people are figuring it out, but just say a little bit more about what needs to be done there.
I think the one thing is to be able to foster buy-in by stakeholders. And so a lot of it, and one of the key things that HARP does is trying to bring together broad stakeholder groups to start to do the education about, what this is and what the incentives are in and around being able to implement these new policies. But in order to foster that buy-in, some of the exercises that we went through when I was working in the jail is we would do like sequential intercept mapping. We would do gaps analysis where like, it's not like the most fun thing you can do on like a Monday or a Tuesday, but like locking people in a room so that they understand the different systems, right? And so you're sort of like, in a way, just trying to kind of foster buy-in so that folks are aware like, oh, this is what the corrections folks are up against. And then the corrections folks are like, oh, okay, this is what the State Office of Medicaid is trying to kind of wrestle with, and making sure that you are sort of establishing that governance up front so that you're sharing across what the challenges are. One thing that I always encourage my correctional friends to do is list out what your needs are. Like, what are your staffing needs here? What are your technological needs here? Like, do you need like a template for a data sharing agreement? Like, what are your needs? And then go to your State Office of Medicaid and say, here's what we need in order to make this successful. Because unless I believe the strong collaboration across these systems is going to be very challenging. But that, again, that's a lift of work to be able to take two systems that don't have a long history of getting together and say, okay, figure this out.
Yeah. Am I recalling correctly, there are federal funds available for the data infrastructure side of this?
Yes, there are.
Are states taking the feds up on that?
In some jurisdictions, yes, they are.
Yeah.
Which
hopefully more. Hopefully
yes.
more will. That seems like a big opportunity.
Absolutely. And the other piece of it too to mention is there are CMS planning grants that have now been released. And the second tranche just came out, and I think those monies will start to flow. So each state could have access up to $5 million. And so, if I could wave my magic wand and I was running a state, I would take those monies and put that into the infrastructure that you need.
Yeah.
The technology side of it, because that's going to be a lift.
That seems like, having that money available. And also, AI is here. AI could help, right? The combination of the two does feel like an opportunity to level up across the board here. Okay, tell me about the State Reentry Learning and Action Network. What is it? What does it do?
So we're doing a learning collaborative with the National Academy for State Health Policy. And in addition to that, we have what we call the LAN, and that's open to all state officials. So part of the challenge is sharing this information across jurisdictions. So wanting to create opportunities. So we have the 7 states that are part of the learning collaborative, and then we have the LAN, which is open to everybody. So folks just kind of sign on, maybe during their lunch, and they can hear about a new topic. It could be billing, it could be data sharing, it could be technology, it could be care coordination, you name it. Just because we wanted to take another opportunity to be able to share what we're learning and share that with the field, because we're creating discrete products that we're pushing out, but also we want to make sure that we're sharing across as much as we can as we learn from the implementation that we're doing on the ground.
Okay, let's talk about California.
Sure.
Which was one of the first states to implement the policy. And actually, several of us from the Arnold Ventures leadership team were out in San Francisco earlier this year in February. And we got to talk with folks from the sheriff's office there and the jail health services in San Francisco. And they were all gearing up to implement their new version of the waiver and all the processes on the ground. And so we got to hear a little bit about just how much work was going into it. But they all seemed really excited about the possibilities here and the opportunity. So what are you seeing there so far now that it's underway?
Yeah, no, again, thank you for the question. So we have the prison system, which went online, I'm going to read here a little bit, February 2025, and there's 6 counties that have gone live. And I think we're going to have 7 more in 2025, which is great. So through our work with, it's around 12 counties in California, it is challenging, these pieces, but they're doing it. And one thing that I thought was really interesting with Santa Clara is that before they actually went live, is they just started testing. Because
short-term
stays are definitely an issue when you're talking about the 90-day piece of it. So if you have a jail,
in jails,
right, who don't have an end of stay date,
right,
what they started to do for their jail population is to look who would go out to court and then be released from court, because then you would have to sort of follow on with care. So they were testing the waters a little bit before they actually, and that is certainly one recommendation that I would have for jurisdictions that are just starting out and is a promising practice, is start doing it and then I think that will inform when you actually have to go live.
So what does success look like here? How do you think about measuring the impact of these waivers? What are your goals at HARP? How should we think about what the outcomes are that we should be looking for?
Yeah, I mean, the one thing, and I mentioned this earlier, is that we have the evaluation and monitoring that are built in to the 1115. So I think there's that piece, and then building in maybe some of the early metrics, I think, for the measuring piece, so that we can maybe get some more of the quick hits to kind of see how many folks were actually signing up for medication assisted treatment prior to them sort of leaving and connecting them with care, and how many folks are being connected within the community. The one thing I will say is that, this is going to be a bit of a seismic shift in how we deliver correctional health care in this country. And not to belabor this point, but it is a lift for folks. But we have a tremendous opportunity to not only make our communities safer and improve health outcomes and possibly save some money here. The one component that I don't think gets enough airtime is the challenge that correctional officers have and correctional healthcare staff have in actually having to care for folks who are really sick, who are in the jail. One story that I share all the time, when I was working in the jail, we had a gentleman with pica, which I didn't know what pica was until I started working in corrections, which the gentleman would ingest anything that he got his hands on, whether it be a plastic fork or you name it. And the corrections officers and healthcare staff would work very, very hard to make sure that he wasn't ingesting things, because that would be bad. But it would just kind of wear over time, because it would be eyes on, as they say in corrections, for someone who's incarcerated, who obviously had a very severe mental illness. And so if we do have an opportunity to be able to like have folks return to community and stay in community, I think, to me, from the public safety side, like, I think that is success, that folks can actually stay in their community, stay connected with their families and the rest of it, and that we can make our community safer.
So win-win. Yeah. It's interesting to think about the corrections officer side. We know that prisons and jails across the country are understaffed. It's a really hard job. It only gets harder. It creates this vicious cycle where people then quit because it's such a hard job. Right. And then it's even harder for people who are left. And so, yeah, it is really interesting to think about how providing more healthcare for people who are inside could actually make their jobs so much easier. It just makes it easier to care for them, easier to keep them safe.
Absolutely. I mean, for the folks that are living and working in corrections, if we can improve the climate that they're working in, and keep them safer, then again, that's another win.
It's a big one. Yeah. What are some of the other difficulties you've seen? What other challenges do people need to overcome here? And what ways are they finding to overcome those challenges?
One that I've heard correctional administrators voice is, we're doing a lot of work to set folks up for success behind the wall, and we want to connect them to care within the community. But if they're reentering into an area where capacity is a challenge,
in terms of healthcare availability,
then that's one thing that. And, we can't always kind of wave our magic wand and create more capacity, but that's one that keeps me up at night about, our ability to do that. But luckily, like, we have community health centers. There was $50 million that, got put on the street by HRSA to help facilitate some of those reentry efforts, which is going to be great, but we're going to need more of that, I think. And because with this, you're going to be creating some demand, on community providers and making those connections. I think that's going to be really important, but that's an additional challenge.
Yeah, the workforce shortage and especially the mental health care space is a challenge throughout the criminal justice system. And there are a lot of places that we could imagine that those workers would be really helpful. And it is interesting to think here about, great, we've made it easier for you to keep your insurance, and now you go out in your community and it's like, wait, there are no doctors. What do I do now?
Right. And on the workforce piece of it, what I saw towards the tail end of my time at the jail is that we had folks that were entering corrections and seeing this more as a career, in wanting to be able to assist individuals who were, reentering, because historically, I remember talking to a gentleman, one of my former colleagues who was there 30 years. He's like, Dave, like, normally, like, once they left, that was it. And like, that's sort of shifted, where it's like you see more corrections like reaching into community and helping sort of foster that. So you see corrections sort of shifting towards that, because there's an incentive there, because they don't want folks to come back. Because anyone that would come back, they would have a conversation. What happened? Like, where did we fail you? And how can we create a plan that will better set you up for success in the future?
Yeah. It's interesting to think about, jail and prison as being an intervention point, right? It's a point at which someone who is clearly struggling in society in some way, they're not on a good path for whatever reason, whatever that means, whether they've committed a terrible crime or they have an untreated mental illness and something else. And if we're not doing everything we can to put people on a better path, then that, again, that's bad for all of us. It's not just them. So how much time do you think it'll take before we know if all this is working?
So with the waivers are every 5 years, right? So like we'll see states that will, start to submit their renewals on those pieces. So that's sort of the longer term, but I've already heard from correctional administrators, like, I'm going to start tracking this stuff now, the metrics, and kind of see how this is kind of rolling out. And due in large part is that, state legislatures are like, how's that going? like, and they want to know. And so the answer that like, we'll get back to you is probably not going to be sufficient.
5 years. Yeah.
Not going to be sufficient for folks who want to continue to support this, because there is a component of this where like state dollars are supporting some of that work. Right. And so that doesn't come without some information that policymakers are going to want to see, to be like, how is this going? And the one thing that I do encourage corrections to do, and a lot of them are already doing this, is like invite your policymakers in to like see the operations side of things. So you can, and also your state office of Medicaid, to see what it looks like to work in a jail and to be in a jail, and what the operational pieces from, intake or medical, and then, the reentry pieces, and getting insight into the programming that's being provided in the rest. I think really it would, I think, assist, some of the policymakers are sort of seeing these pieces, so that they can get a sense of what the implementation is looking like on the inside.
So let's talk about the costs a little bit. What is this costing states?
I think a lot of corrections they're starting to sit down and take a look at, do I need like 3 or 4 FTEs and points of contact in order to be able to implement these pieces? Because you sort of need someone to be running like the day-to-day, and then you have your reentry specialist. In corrections, they do have the option to actually utilize their own case managers for like some of this work if they want to, or they can have someone else, from the outside, like a community health provider, be able to provide some of the case management work. So looking through some of those pieces. And I think another big cost driver is putting up your electronic medical records systems, because some of those are different, and some of those don't exist. So building it or improving it, and also building in functionality into those systems so that you can do the billing component. So that I think the tech build is certainly one that I think could be a cost driver on these pieces. But like I said, there are resources that are available, for that. And hopefully, as part of these 1115s, there are reinvestment requirements that you need to make. And these are monies that are going to be flowing back from the federal government, so that you can reinvest some of these dollars in order to support some of the implementation, because we need to talk about like long-term sustainability of the component parts that you're putting in for implementation, because the seed money is great, but like corrections needs to know that like that's going to be there long-term for them in order to support the 3 or 4 individuals that they're going to be hiring to kind of make all this sort of hum, if you will.
Right. And the idea is if it reduces the cycle of people back through jails and prisons, then that saves a lot of money. Incarceration is really expensive.
Exactly.
Yeah. Let's imagine we're looking back on this in 20 years and it didn't work. What went wrong?
The one thing that I have heard early on is that for some jurisdictions, as they were moving through like implementation plans, which is another requirement that you have to have post-approval, is that I wish that I actually had corrections perspective in this, because there were blind spots that I didn't see. So like I said, it's going to take strong collaboration across these two systems in getting everyone at the table early on, I think is critical to success. So if we, I'm going to reject the premise a little bit, but let's just say for the hypothetical, that, if we look back and say like, what were the challenges? It would certainly be, I think, not having the right people at the table for the conversation to make sure that we're doing the implementation pieces correctly.
All right, my last question. All of this operates through Medicaid. Not all states have expanded Medicaid to include low-income adults without dependent children, which is the highest risk population here. Not all states want to expand Medicaid, and they're not going to expand Medicaid. But our goal here is to increase access to healthcare. It doesn't have to be through Medicaid. Medicaid's a great policy lever we can pull because of the role it plays in this country. But if your state doesn't want to expand Medicaid, what could you do? Right.
That's a great question. I mean, the one thing I will say is that the Medicaid program is well suited for this because of scalability in the quality and the accountability, the sustainability, the evaluation, and all that. But to answer your question, there's things that you can do to support reentry right now. One thing that we did back when I was working in the jail, and this was just state dollars, we did in-reach and post-release navigation for folks with co-occurring substance use disorder and mental illness. So it was a case manager who would do the in-reach, which is actually kind of what the waivers are doing now. And then they would do post-release navigation within the community, connecting those folks to care. And again, what we saw over like a 2-year period was that the recidivism rate for that was 10%. And you could use state dollars in order to support those pieces. Because the one thing I will say is when I was working in the jail, we had that co-occurring model that we use. And then we also use navigators for the MAT model that we had. It is the case management piece of it. Like if you want to fund that with state dollars or opiate remediation dollars or the rest of it, that's something that you could exercise that I felt was sort of like the secret sauce and making sure that folks were able to, connect to care. Because I even think about my own healthcare. It'd be great if someone would like help me kind of navigate
Totally.
some of it. So if I had a case manager, that would be really helpful, especially with my kids and like their appointments and the rest of it like that. I think, especially to your earlier point about there's a lot of other stuff that folks are, considering upon reentry, like employment and housing,
where
and
to
the rest
live,
of it,
all that stuff.
all that. So to have that person who's gonna, meet them at their end of stay and then talk about what the plan is, moving forward, because what could have occurred, behind the wall with reentry planning, it would be kind of restarting on day one. Like, okay, you have this appointment tomorrow. Here's what we're going to do next week and the rest of it so that they feel supported. Because I do feel like historically, some folks who have been incarcerated, that they've been sort of let down. And so there's a trust that needs to happen between the casework and that individual to make sure that they're successful upon reentry. But there's a real possibility there to be able to do that. So, if you're nowhere in this, and you're just sort of starting out, like that's one thing that you could do to kind of get things started.
Yeah. Amazing. Well, thank you so much for joining me today. I love learning about this project. It's so important. Can't wait to see the results of how it all plays out and all the things we're learning from it. If people want to find out more about HARP, where should they go?
Please visit our website. And also we are on social media on LinkedIn. So please take a look because we are always putting out, like I said, like new products for the field, because that's one thing that we feel is really important. As we learn, we want the field to learn as well.
Great. Thank you. Well, that's all from us. Thank you all for listening or watching. Please subscribe for more conversations, and we will be back with another insightful conversation about criminal justice innovation soon. Bye.